joining our Project ECHO tonight as part of the Cancer Survivorship Series. We are back to, if you want to call it, normal programming after our COVID and cancer mini-series we held in April. So thank you for everybody who participated in the mini-series, and we are glad you are here with us tonight. The other thing that we want to highlight is this topic tonight, which is tobacco, smoking cessation, really does kind of dovetail nicely from the cancer and COVID sessions, based on the fact that obviously those who have a history of or current users of tobacco, especially smoking, are at a greater risk. And then throw on top of that the fact that cancer patients and cancer survivors have some of the highest risk for COVID. I think it does dovetail nicely. So tonight we are excited to have some content experts with us to share some really up-to-date information, not only about the risks and opportunities related to smoking cessation and tobacco cessation, but also some great case studies. And so Treza Hutchinson is a clinical health psychologist in our Department of Population Health at the University of Kansas Medical Center. And Sherry Murray is a nurse practitioner with our bone marrow transplant and survivorship program at the University of Kansas Cancer Center. So they are joining myself, Jennifer Klemp, and Dr. Christian Sinclair as we sort of embark on this next step of our survivorship series. So we're really glad to have them with us tonight, and we look forward to an engaging discussion. So just to go over our kind of agenda and topics for this evening, we'll go through our fidelity as we always do. And here is our continuing education statement. Obviously, you will be getting CEs for this and for your participation. The next slide will highlight for us. We have a tiny bit of lag tonight. Sorry about that. Let's see. Maybe it's just me. There we go. I think it's these little page flip things that are in there. All right. Our conflict of interest. Yep, we have a weird delay. Sorry about that, you guys. Okay, conflict of interest disclosures. Once again, you will see all the presenters listed as well as our faculty, and I believe I'm always the one who has the conflict of interest, so you can read about that. And if you have any questions, feel free to ask me about that. Here are your CEU identification code for tonight, which is 56 miso. Makes me want to go get some sushi, which we can't really get, but maybe we'll order some. So 56 miso, and you need to do that by next week, next Tuesday, to get your credit. Either text it in, log on to your EADS account, or go on to the app, and that you will get your CE credit for this evening. This, of course, is made possible through a cooperative agreement through the Centers for Disease Control and Prevention and the University of Kansas Cancer Center and the Masonic Cancer Alliance. So thank you to our funding partners. We're going to start with our check-in tonight. We already have some of you who are checking in on the chat box. These are our organizations, obviously, who are participating. And so let's go and see everyone and say hi and see who is on. So we know we have our Lawrence Memorial Hospital gang of Amy, Dr. Barr, and Lori. Dr. Barr and Lori can't join tonight. We're sorry about that. Vicki Portwood from Coffeyville is on. And then who else is on? Who else do we see? Let's stop sharing real quick and we'll take a look around. All right. Does anyone else want to say hi? Carla, you're on tonight. Do you want to say hi?
Hello.
Hello. Good to see you.
Good to see you.
Great. And we have some new folks. So with the folks, Dr. Richter and Dr. Fazaru, would you like to say hi and introduce yourselves? Because you're new to the group. Oh, you're on mute, Kim.
Sorry about that. Hey, this is Kim Richter. I'm at KU Med in the Department of Population Health. I conduct or direct inpatient tobacco treatment program in the hospital.
Great, thanks.
And this is Babalola Fashiru. I'm also in the Department of Population Health, and I
I conduct the training. We actually have a training program for tobacco treatment specialists. I direct that training that is funded by Cancer Survivorship Foundation. And I also do research among underserved population, which include African Americans, American Indians, and also hospitalized patients. Look installation research.
We're glad to have you both tonight. Jenny, we haven't seen you for a while. Good to see you.
Hello.
Hi.
I am an oncology nurse navigator at Olathe Health, and I help coordinate our smoking cessation program.
Great. We're so glad to have you as part of it. And how about Karen and some of the MCA folks? And since Karen's relatively new, I want to make sure everybody knows who you are.
Thanks, Jen. I'm Karen Dennis Collar. I started with MCA, about 3.5 weeks ago. It's been a very interesting time to get started, and I'm the Psychosocial Services Director. So I'm excited to get started with some tobacco cessation work for the MCA. So it's timely. Thank you.
Yay, great. All right. And how about our folks from telehealth? We have Jan and Dr. Wright. Want to say hi?
I'll say hi. I'm Shauna Wright. I'm a clinical psychologist, and I work as the associate director of the KU Center for Telemedicine.
Okay.
Good afternoon. I'm Jan Lyon, and I'm the project manager for KUMC's Project ECHO.
Great. Good to have you guys. And we have Vicki down in Coffeyville, if you want to say hi. And then we have Hope Crable. Anyone else want to chime in tonight before we, Tracy and Trish, the crew, our crew. All right. Well, great. Well, thank you all for joining us again tonight. And Treza, if you want to pop your slides back up, we'll introduce you guys once we dive into our content, our special guests for the evening. And thank you all for having your screens on and for saying hi tonight. All right, thank you. All right, and you can go down to, yep, there we go, perfect. All righty. I don't know if it's going to let me go yet. I think you have to give me permission again for some reason. Sorry. Or why don't you just click ahead, Treza? Here we go. Once again, we do record these sessions. So if you are uncomfortable with that, feel free to hide your video, but we just want to let you know that, and you can keep clicking through, Treza. Sorry about that. We are glad to see you. So thank you for showing your face, and please mute when you're not talking so we don't get any background noise, or maybe someone has a little one at home, which we know it can be a little distracting. Go ahead. And we're going to start with a poll, and a lot of you are now used to the poll questions. You'll see the poll come up. It's always a green box, and we'll go ahead and share the responses. So the first poll question for tonight is on the next slide. And in the past month, have you actively counseled a current cancer patient or survivor on tobacco cessation? And yes or no? Okay, so it looks like we have, Tracy's going to share the results. Some of you have, probably some of you who are providers in the clinic, but a lot haven't. And so that gives us some opportunities to really think about places tonight, as you hear from Dr. Hutchinson and from Sherry, opportunities for counseling your patient. Okay, next slide, Treza. And just a quick reminder, the reason we're doing the survivorship series is this really gives us an opportunity to talk about issues related to our cancer patients from the time of diagnosis through the lifespan. And we know that caring for our cancer patients truly is an interprofessional and multidisciplinary experience, both for our care teams, our institutions, and for our patients. The survivor is the locus of control, sort of in the middle of this care team. And so we're always looking for ways to engage our patients. Through our echoes, we're hoping to engage this statewide and regional community of practice where we can talk about issues that impact all of us, as well as best practice and opportunities for research for our patients. And we also want to get access to experts who maybe are in different areas of the state, of the region, and across the country. So through this community of practice that we're building, we really want to have these opportunities to engage with you and to engage tools and strategies for caring for patients across our region. Next slide. And as we kind of dive into the hold on a second. We have a little lag. I know the lag is it's a little slow tonight. Sorry.
It shouldn't lag. You think it would lag on my end, but it did lag and it didn't go.
It's okay.
Weird.
There we go. And as we think about our patients from sort of head to toe, this is where truly understanding the risks that our patients walk in the door with, the risks that they develop as part of a cancer diagnosis and treatment, and then the long-term, late and long-term effects. This is the picture that we're really trying to couch when we talk about survivorship. And it's interesting because the more we think about accreditation standards and the more we think about whole patient care, it does get challenging to really think about how much assessment do we do when a patient onboards, how much do we do ongoing. But some things, like the topic tonight, are very timely in that it's not just a one-time assessment. These are things that we need to be doing across that patient journey, and we need to do often and frequently for our patients in order to really address some of their greatest risk factors that can be not only a risk when they walk in the door, but a risk for future cancers and for treatment complications. So tonight we have, as I mentioned, 2 content experts with us, as well as a whole team of other folks who are on the session tonight. And so I'm going to kick it over to Dr. Treza Hutchinson, who is a clinical psychologist and an extraordinaire at tobacco cessation counseling, and let you take it from here.
Thank you. At any point, if you guys can't hear me, let me know, okay? So we're going to start with a somewhat of a poll, but we're going to use the chat to respond to it. So I'd like you to think about the concerns that you have about tobacco being treated during active cancer treatment or treatment survivorship care. Like, what do those concerns look like? And I'll go ahead and give you a few options. Of course, you can put ones that aren't on there. Maybe choose 1, 2, or 3 that are your concerns. So hoping everybody will be chatting. I can't see the chat, but we're gonna have people monitor this for us and let me know. And these could be, as you can see, thoughts that you have about it, training, worried about the patient.
And so Treza, some of the points that were made were the patient is too stressed at the time. Vicky from Coffeyville says stress, lack of interest, time, and the time to address those issues. Dr. Registars is afraid that the patient will feel overwhelmed. What else do we have? We have lots of great answers. Patient has other stressors. So that seems to be one that's common, is that the patient has some conflicting stressors.
And we have a lot of compassionate people that are just trying to help people through a difficult time. And the answer is that all those are right. Those are all barriers that we find. This study specifically looked at oncology populations and looked at the providers' barriers, provider level barriers, and categorized them. And as you can see, the second one was worried about putting stress and guilt on the patient. So that is a realistic concern that people have. And then of course, all of these others maybe not having the training or the skills that they need. So we're hoping that through this talk today, not only will you see why it's important despite all of those barriers, but also maybe come away with a few of the tools and a little bit of training that would help you implement them. So thank you for sharing that. I appreciate it. So I'd like to just start by looking at a few statistics today. And decades of research have pointed to 12 different cancers that are related to tobacco use. And I guess you can say tobacco use can cause cancer. There's a depicted here in the diagram. You can see which ones. A third of all cancers are tobacco related. And what that means, I think, from a provider's point of view, and I would actually love you guys to react to this as well. Are they used to using the reaction button at the bottom that you trained me on, where you can give a thumbs up? If you guys can give a thumbs up, if you've ever in the care of patients, you've ever had someone ask you point blank or express concerns, did my smoking cause this cancer? Who has experienced that? I would be curious to know if a few people have heard that. Because I've heard it, and I don't treat in oncology. So, and as the responses are coming in, so what do you say to that? I mean, I think personally, you have to be somewhat honest without being blaming or judgmental, in that, and maybe take a future focused point of view. Like, let's focus on the here and now. You know, we can't say what caused your cancer. We can't say that. We do know there are cancers that are related to tobacco use, and what we also know is that there's a lot of benefits to quitting, and that's what we're going to focus on, is how to help you. So that's probably a more responsible response that kind of sheds some of that guilt and blame that you all are worried about, for good reason. And as you take a look at this list, I'm not going to read all of these off, but we do know that continued tobacco use is detrimental in cancer care. And just kind of thinking about all the conversations I've had over the years, even though I don't work in oncology, a large proportion of the patients I work with have either had cancer or have the cancer diagnosis. So they've expressed concerns with it not being a good time right now. I am going through a lot. I am overwhelmed. A lot of the things that you all just said, this just doesn't seem like a good time, or maybe my provider told me it wasn't a good time, so I don't think I want to tackle it right now. And really, if you look at this list, there's so many reasons why continued tobacco use is so much worse than that, and why we should push through it and treat it. And especially if you look at that top one, we know that if they continue to smoke or use tobacco, that there's actually drugs that will not be metabolized to their best effect, and they just may not be effective treatments, or as effective as they could be. So we always want to maximize cancer treatment, and one way we can do that is by treating tobacco. And then also, a concern has to do, and fears again that patients share with me who've survived cancer, is I'm so scared that my cancer would come back. And so maybe they've expressed that to me when we're talking about risks of continued tobacco use. And so that we know that's true. So of course you join with them and say, yeah, I mean, you do have a higher risk of recurrence, and or even of developing a secondary cancer. And we do know that it even doubles the risk of all-cause mortality. So again, many good reasons to address this in cancer care and survivorship. But how do you pose that to someone, right? And I really like this slide the best, because if you like to take a more optimistic point of view, and you're dealing with people who are in a time of their life where there's enough fear going on and concern, that if you can maybe pose it in a more positive way, where they focus on the benefits of quitting, that might be more tenable to them and to you, right, as a provider. So I think you'll get the slide deck, and again, I think this is a great slide to just summarize some of the talking points that you could develop and all the wonderful benefits. So for all the benefits of quitting, do people continue to smoke after a cancer diagnosis? Yes, they do. And some try to quit and then relapse, but many never try to quit. So we end up with a lot of smokers that last stat there, maybe 2/3 are continuing to smoke past their cancer diagnosis 2 years out. And that does drop a little bit if you look 4 years out, but it's still over half of them will continue to use tobacco. And just looking at the prevalence rates, if you think back to that diagram that had the 12 different cancers, those people who have those diagnosed cancers are going to be more likely to continue to smoke. They're going to have the higher smoking prevalence rate, so almost 1 in 3, versus someone who has another type of cancer or has no cancer history. And there's certain types of cancers maybe that might have higher prevalence, bladder, lung, ovarian. There's different studies that have a little bit different results there. So we know that addressing tobacco and cancer care has very wide support by all these agencies here, and I'm sure you're familiar with most or all of them. NCI, through their Moonshot Initiative, they funded over 40 NCI designated cancer centers, and we were lucky enough to be one of them, led by Dr. Richter, who's with us today. And that initiative, some of the tools that we've provided for you was developed as part of that funding. So I appreciate them and them funding this. And this was one of the studies that they put out, papers that they put out recently, and I also included that in the toolbox because it's a very short read, and I think it's a really interesting one. One point they make is that don't forget the cancer survivors. I mean, you're not just dealing with active cancer treatment. And then they also gave some really neat ideas that were really collected from the over 40 sites on how to increase tobacco treatment reach. And I won't read these off, but it's anything from maybe doing some telehealth and telephone follow-up, maybe scheduling appointments when they're already, the patient's already coming in, so try to piggyback on those appointments. Possibly even trying to treat more people by offering it a different way, like through opt-out care, which we can talk about later if anyone's interested in knowing more about that, or doing warm handoffs where you're actually, in the session, I guess this is more pre-COVID, like, let me have your phone, I'll sign you up right now. But maybe you're like, you have your phone, let's sign you up. Is there much lag, or am I pacing good here, everyone?
You're doing great. And let's stop to see if anyone has any quick questions or any comments about what you just covered, because I think, what you brought up is so poignant in that we think about this, sometimes at certain time points, but we really need to be thinking about it, during the whole course of the patient's journey.
Yeah.
And does anyone have any comments or suggestions or strategies that you use? And I think, like Jenny, for instance, at Olathe, when are you bringing up smoking cessation for your patients? Is it all the time? Is it, every visit? How do you do that? And how do you get patients referred to you?
The majority of my patients are coming to me by way of my lung screening program. Excuse me, I have banana in my mouth.
Did I get you right when you had a snack? I'm sorry.
Yes, you did. That's okay. You can't see me, so you don't know that.
So the lung cancer screening program, that's a great strategy. And on an average basis, if they do, if there were 10 screenings done, how many of those patients actually follow up and see you as a referral?
The number is actually very low, just because those patients are not ready to quit. But anytime I can plant that seed is an opportunity to try and help those patients.
Yeah, that's a great point. So you have to do repeated touch points, which I think Trez is going to get to. Thanks for sharing, Jenny. Any other comments as we shared? I think that's a great strategy, is through the screening program. Okay, great. You're back up, Treza.
And it was a point I meant to make, and I didn't exactly, that it is a teachable moment, a cancer diagnosis, but it's also important to do it at different points. And I appreciate what she said about, they're not ready yet because their screen came back negative. They feel like they're good for another few years, But teachable moments are times like hospitalizations or having a cardiac event or having a cancer diagnosis. There are times when it's actually a good moment to intervene because people are already focusing on their health. So we tend to think that it's better to do it earlier, and there is some research to back that up. This one meta-analysis that I have up here, study 1, looked at 10 randomized control trials and 3 cohort studies, and their only real significant findings were when they pooled pharmacotherapy plus behavioral counseling studies, or studies that included both of those aspects. They found some significant impact on smoking cessation, but they found this rate. And I'm so sorry, I forgot to add the odds ratios for that second point, but the range was all up to almost 4-fold. But it's even greater if you do it earlier. So the earlier you intervene, the better when it comes to tobacco and cancer care. And in the second study, I just want to make one take-home point on this one, is that regardless of if you have a current cancer diagnosis, you're a cancer survivor, or you have never had cancer, you can achieve very similar abstinence rates. So in this large study, they didn't find any difference in abstinence between what people were able to achieve all the way up to 9 months.
And Treza,
So
you know, if
yeah.
there are patients, because I know a lot of our surgeons, they really want patients to not be smoking for a period of time before they take them to surgery. Do you or Sherry have any comments on, you know, what's the standard, and is that a good window of opportunity, kind of like you said, the teachable moment to capture those patients?
Sherry, do you want to answer?
Well, I know that ortho and plastics don't want their patients to be smoking, current smokers. So they will not take people to surgery a lot of times until they do quit smoking. And so can be very highly motivating. And now our patients don't go to surgery necessarily for BMT, but I think more and more surgeons are requiring that because they know that the healing process is affected by active smoking.
Absolutely. And especially like you brought up plastics. I know that our plastic surgeons are pretty good, pretty much sticklers for that because it affects their outcomes as well. And as you said, complications for the patient. So it affects them both for cancer-related surgeries as well as for any type of reconstructive surgery. So just important things to think about, those teachable moments.
My other job is I do quality improvement. So I'm actually looking in the medical records, and often the advice that I actually see besides talk to a patient about the importance of quitting smoking is talk to a patient about how they're not a good candidate for the surgery. So there is a lot of intervention in the surgical onc and surgical teams. Yeah.
One other thing, if you feel like a patient might need surgery coming up, to give them that warning, so because people don't know that and they're surprised, and so then they can kind of get a better mindset about quitting, and it gives them some more time if you think they might be going to surgery in the future.
Yeah, or transplants. I mean, there's all kinds of things that we see it all the time where people, when you're treating people, that they're like, my surgeon told me this, or my doctor told me this. It's scary, right? So yeah, as much heads up notice, I guess, because it takes a while to quit, so we need to give them some time to work on it. That's for sure.
Well, and Dr. Sinclair asked Treza too, especially since you're reading through the medical records, is that decision-making about surgery, is it patient-centered? So are you seeing a bi-directional conversation there, how it's documented, or is it literally the surgeon just saying, hey, you're just not a good candidate?
Yeah, it's interesting. Sometimes I'll see them, I'm looking through progress notes, right? I'm looking through the actual, what they've typed out in their note. And so sometimes it'll show both sides, like I told them this and they express they understood. And it may even go further to say patient is going to work or start Veronicline or do this. So it'll often have a plan afterwards. I think most of the times I see that there is some follow-up of how they're going to try to quit. Although there's sometimes where patient said they're not going to do it. So I don't think they just leave them hanging and say, oh, I told them they can't get it done. There is some type of assessment and a plan. We have good docs. Did that answer the question? So what do the guidelines say? So I'm going to go over the NCCN guidelines, and we also, that little toolbox icon means that we included at least a link to this in the toolbox, I believe. I would suggest creating your own account if you don't have one and accessing it that way. I found out if I tried to print it for you, it said very blatantly that I was infringing on copyright laws because it has my name printed on it. And I didn't want to do that. So go access it yourself. It's super easy and it's free. But the NCCN guidelines say you should document the status of all patients, update it regularly. Any tobacco use in the past 30 days should get some type of intervention. And this is the way they step through how they go through the steps. First, you do some history taking or evaluation. Then you do a motivational component. Maybe look at the you know, the pros of quitting, that sort of thing, address their barriers a little bit. Then you assess their readiness to quit. If they state they're ready to quit in the next 4 weeks, which is a pretty big, you know, window to look out, then you're going to initiate treatment, which will include a pharmacotherapy. Otherwise, it's kind of interesting how they word it. Otherwise, they also want you to provide intervention, even if they're not ready to quit. In fact, they want you to encourage a reduction goal work, or kind of on the road towards quitting, and start a pharmacotherapy to help that. So, and then to look at what that treatment is going to include, evidence-based counseling, pharmacotherapy, and retreatment. And again, kind of going back to that study, the only one that found results is where you do that combination. So there is definitely a lot of science behind why both of these parts of treatment are important. As far as doing the follow-up, there's a range on that recommendation, because you can shoot out 3 weeks if you have to make it coincide with one of their visits when they're coming in, just to make it easier on the patient. But if you're going to start them on a new medication, a pill like either varenicline or bupropion, it's probably good to have a shorter follow-up time point. And you can do that over the telephone as well, to bridge that until their next visit. Even though there are 7 FDA-approved smoking cessation medications, NCCN guidelines actually create a top-tier option, which includes either varenicline, which has the highest quit rates for a single medication, or combination nicotine replacement, which includes pairing the nicotine patch based on their cigarette smoke per day with one of these lovely short-acting NRTs you see to the right on your slide. So it's really doing one and the other. If they don't do well on the first course that you choose, then choose the other first-tier options. So if you start them on varenicline and that's not really working well, or they're having side effects that can't be resolved, then you switch them to combination nicotine. And then if they fail on both of those, you can either go back to the first one you tried, or you can switch and consider bupropion, either with or without nicotine replacement. Don't worry, you don't have to memorize everything. There's so many wonderful guides out there. The one on the link on the bottom is the chart you see in front of you. It's really nice because it's just a one-page snapshot. Also, Mayo Clinic has one that includes smokeless tobacco treatment guidelines, so most of our counselors copy of that handy. And then there's 2 others that I really like a lot. The American Academy of Family Physicians has a nice one. I think that's through this thing called Prescription for Change. And then, of course, the U.S. Surgeon General's report has several pages of table that has a lot of good information as well. So because I was told that it might be a hot topic, I went ahead and added in just a few slides on talking about cautions to medications. And don't get daunted. I know that looks like a really big list with varenicline, but actually most of these are extremely rare, and there's no absolute contraindications to varenicline, but there are cautions to consider. The one that you'll probably hear the most, I guess, patient-related barriers to, possibly even provider barriers to, is the mental health. So, and there's a whole history to this, and I'm not going to go into it, but in the reference page on these slides, there's something called an Eagles trial, and you can always Google that, pull it up, and take a read. But basically, you know, if somebody has a history of psychiatric illness, there's not too much of a concern, especially if you just ask them to monitor their symptoms. And if they do have a history, you can still consider it, but again, you know, as long as they're stable, and then just ask them to monitor any changes in mood or behavior. But kind of looking at anything, or looking at the ones that might be related to cancer, disease-related renal compromise is one concern. And then because of the seizure risk, brain mets, CNS tumors, anything like that, you might rule this medication out for your patient. And then, of course, there's that nausea is probably the most common side effect with varenicline, but if they take it correctly, which is with a couple glasses of water and after a full meal, it probably won't cause problems. Even if it does, I guess I would just say monitor your patient. So if they're already experiencing nausea and it gets really severe after starting varenicline, despite taking it correctly, then maybe it's not the right medication, but you can always give it a little bit of time and see if it gets better with continued use. And if not, you know, there's always switching. Oh, you know what, let me go back. I also forgot another part of the NCCN guidelines has to do with upcoming surgery. So if they also say choose the NRT option if there's a surgery within 7 days, and the reason for that is because varenicline, normally you use it for about 7 days before trying to quit. So they would advise you maybe to do NRT if all things else are equal. And then just a few notes on bupropion, because it can lower the seizure threshold. Again, our cancer-specific one will be the same as with varenicline, and any of these other conditions will probably be a contraindication. And there's other cautions as well. I think one of the things you'll have to think about is drug interactions, and specific to cancer would be tamoxifen. So in breast, you'd probably need to, this would be the one thing I'd say you'd want to memorize from all the different interactions that you have to be concerned about. But if you're a non-prescriber, don't worry, you're going to be working with someone to figure out, what's appropriate or not appropriate, so you don't have to memorize all the drug interactions. If you are a prescriber, while I'm going on, I would like for you to chat what you use to check interactions. Like, do you use UpToDate? Like, what do people use? I'd be curious to know how you use that in your when you're thinking about your algorithms, or how you work through which medications are appropriate. All right, but I'm going to keep going on. And then again, neuropsychiatric symptoms are again, that's because that's a rare thing. There's no black box warning on that either. Okay, do we need to take a break or keep going?
I think that as you get into this models for prescribers and kind of going through this, then we'll ask when folks kind of incorporate this into their practice, so you can chat that in, and we will also have a little discussion around that too.
Yeah, did anybody chat in what they use for checking drug interactions? If they
we saw
do
an
that?
UpToDate. There's an UpToDate. And I would assume that those of you who have a pharmacist as well, that might be an option where they're very helpful if you have a cancer center or a pharmacist on hand as well. Yep, clinical pharmacology. Yeah. Great, Vicki.
So I'm going to work to briefly describe a brief model of intervention to hopefully give you just a model for you to think about as you're thinking about the different steps and how to work with your patients. So of course, it starts with asking that assessment component on the 30-day question. And it is important to do it in 30 days. Again, referring back to the work I do, where I'm looking in the medical records, that I'll see people that are listed as former smokers and their quit date was yesterday, or it was the day before their first cancer center visit. So there's tons of times when they'll come and say, "Oh, are you a smoker?" And the person will say, "No, I'm not a smoker. I quit this morning." So remember, 30-day use is a pretty important measure there. And then the next step would be advising, and this would be clear, concise, relevant to the patient and their current condition, and just consistent across the entire health care system. The next, oh, whoops, I did the wrong thing, sorry. And then, so next you can assist. And so assisting can be, as a prescriber, the most important thing you can probably do is provide a prescription. And engaging potentially in a little bit of treatment planning if you're able and have time. But remember, you can refer some of that out, some of the behavioral planning, and referrals can be made to things like quit lines, apps, texting. There's a cheat sheet in your toolbox that will have a list of a lot of those things, and I'll refer to that a couple of times. And then for a non-prescriber, it's really going to look the same, except once you get to assist, it may be just talking to them about which medication is correct. And then when you go to referral, you're still going to want to make sure they have some behavioral support, but then you also will refer to, to hopefully get a way to link them to that prescription. I don't know if there's ways to figure out if you can pin to orders to where there's a prescriber that you work with that can help you get that, or someone within your health system. When all else fails, sometimes you do have to just, refer them to talk to their family or their primary care. It says prescription. Oh, the primary care. Okay, I thought it said prescription. Provider. So primary care, their PCP, to help them get that script. Yeah. But in our hospital program, we actually use, Kim, I don't know if you're on mute. What is it, Volt that we use? Don't we kind of message people, attendings, to get these scripts?
Yeah, folks either use Vault or regular text messaging to both the pharmacist, the floor pharmacist, as well as the resident assigned to the patient. And they receive it very, very well.
Yeah, it seems to work pretty good to do that, and make a note in the chart as well for that recommendation. So we do that within our own health system. They run a very, very awesome program there in the hospital. And then I won't have time to really go over the numbers like I wanted to today on this slide, but this is just to remind you that every little step that you do is important, and it's important to do it consistently, because if you do it with every patient that uses tobacco over time, you're going to get more people quitting just by this whole number needed to treat, you know. So the more people that you advise to quit, you're going to get a quitter. The more people you assist with different pharmacotherapies, you're going to get more people quitting. So again, each step is important. I do want to plug telephone counseling for a minute, because there's so much research on this as being a very viable and effective way to deliver increased reach across different populations. And our state quit lines, they're amazing. I mean, they have trained people. You don't have to do much. You refer to them. They make all the phone calls. So they work on linking people to care. I do have to say, though, that even though we all seen that Can Quit card, I have it in my hand. You see it's in my hand? No. The Can Quit card, even though it's nice to hand it to the patient, it's actually better if you can do one of these other referral methods, because, maybe, I don't know the percentages here, maybe less than, different studies have found different things, that even some less than 1% with different methods will end up connecting. So there's a web form, there's a fax referral method. I don't think any of the systems on here probably have the e-referral method, because it's a whole thing, but definitely the web and fax are easy to do, and they will send you a feedback report. So you'll know if your patient has been connected and the outcome of that, and you can add it to the medical record if you'd like. And then warm handoff, I briefly mentioned earlier, it's where you're like, give me your phone, or yeah, anyway, let's call them together, right? I'm not going to go over this, but this is information that's in that handout I told you about in the toolbox. So texting options, there's webs, there's apps. There's a lot of research that shows the more interactive like websites and apps are, the more likely they are to lead to better quitting. So there definitely are some that are a little better than others.
Treza, could you flip back one thing though? I saw something new that I hadn't seen before on this slide.
Okay. Oh yeah.
Which is has to do with Juul. I saw ditch Juul. I like that. So is that as we have all these different methods of accessing tobacco, is this something that, like Vicki or Carla, are you seeing a lot of your adult cancer patients utilizing alternatives like Juul or some of the vaping products, or how does that look are they more traditional tobacco smokers?
Well, not necessarily in the cancer center have I seen people with the smokeless tobacco, but or not smokeless tobacco, but the vapors, but like going to the bowling alley, there's lots of those out there.
And are you having to use any different techniques to, do you have to ask specific questions, or is it still using the same, questions you always ask your patients and to get them to sort of, to share that they are vaping with you?
Some patients will share that they're vaping, that they're using vape to try to quit actual cigarettes. And they even ask about, what do you think about using the vapes to do that?
Well, I would say we see mostly in our practice traditional smokers, and that probably has to do with the age range that we tend to treat, adults. But I remember long ago, there was a Nicotrol inhaler, which was nicotine, and that was marketed specifically to quit smoking using a nicotine inhaler. And some people had some success with it, but in general, it seems to me like most people feel like they're not quite ready yet, because they just have gotten a new cancer diagnosis, a lot of different changes in a short amount of time, and it might be a conversation you have to have with them several times, I think.
Great. Thank you for sharing that. And sorry, Treza, I had not seen ditch Juul, but it just drew my attention. I was like, ooh, good. Yes.
That's okay. I'm going to wrap up here because I really want Sherry to have time to talk. Oh my goodness. So let me just make a plug for this compassionate care. and say that use the skills you're already using. You're already using compassion in dealing with people who are going through cancer and cancer survivors. So use those same skills to address tobacco. And the reason it's so important to be non-judgmental is because you want people to be honest with you when they fail a treatment and they're struggling, and you want them to not have that like that shame and guilt that would cause them maybe to not reach out for help when they need it. And then finally, here's some talking points. I think you get the slide deck so you can take a look at them. It's just important to develop your own spiel over time. But this one is specifically for people who tell me or you they want to do a cold turkey. Okay, so remember that's what that slide's all about. And then don't forget follow-up. I can't just breeze over it because it is so important. It's important to ask them how things are going, and the way you pose it, it's probably not like, hey, you still smoking, or you quit yet? It's more about, how's it going? Tell me how it's been going with your tobacco or trying to quit. So just, again, allowing them to have that space to tell you if they're not doing well, and being able to check in on all the different aspects and making adjustments. So adding an extra medication, adding an extra support that maybe they rejected the first time around. So, all right.
And going into Sherry, just real quick, we have one question in the chat box. The question is, I had a patient that was doing chemo education who brought their vape pen and said it didn't have any nicotine in it. Should they be encouraged to quit this also?
Is that question for me?
Yes,
I mean, how do they know it doesn't have nicotine in it?
You tobacco experts, yes.
How do we know it doesn't have nicotine in it would be the question, I would say. I would say they're unregulated, and although some have identified they have no nicotine, there's actually studies that showed almost 90% of those actually do contain nicotine that say that they don't. So it's probably not a good thing, but, and there's other chemicals that we have to worry about as well.
Yeah, so true. Great. Well, thank you, Treza, and thank you for those questions. And we're going to dive into these. And so we want to thank our great speakers, and you'll see both their contact information was on that last slide. And there's all the references. There's lots of good stuff in the toolbox. So thank you guys for your participation tonight. Thank you to our content experts for sharing your time, for putting this information together for everyone. Make sure that you do, if you want continuing education credits, go ahead and contact through the 3 different ways using the code 56MESO. Next month, we will be talking about cancer rehab and lifestyle with Dr. Megan Clark and Dr. Jill Hamilton-Reeves. And as always, you can get all the information you need, plus the resources, at the Masonic Cancer Alliance website, and you click on the left side, and we have a new tab called tele-mentoring. So you can click on that tab and you can get access to all this. So thank you all for your info, and thank you, Denise. We see Denise from Hayes joined as well. Good to see you guys, and we will see you next month, same time, to talk cancer rehab and lifestyle. All right, have a good night and be safe. Stay well.
Thank you.
Thank you.
Bye.